another seemingly simple but tricky topic to discuss. As usual, I've taken a fairly principle-based approach, which people that have been attending the last few sessions will note is commonly the case. But things like this, like fingertips, it's very difficult to be dogmatic about it. And that's one of the things that makes it so interesting and potentially difficult, is that they're just so variable. So that's what we'll talk about quite a bit tonight, is variability, and we'll try and give some idea about principles. So we will get underway because everyone will be wanting to go and do something else. If you have any questions as we go along, please just drop them in the Q&A, and along the way we might stop and answer some questions. Otherwise, we'll do our Q&A at the end. So feel free to ask questions. It's much better if we do things live with some feedback. You do my usual gory picture disclaimer. There's a few extra gory ones tonight, potentially. Fingertips can be that way, so that's probably what most people are going to enjoy, however. Now, starting off with a little question, because I always like to have a little question, particularly with a complex topic. In your consideration, what's the most difficult thing when treating fingertip injuries? Is it the bone? Is it the nail bed? Is it working out what soft tissue reconstruction there is, or is it the timing of any replantation if you've got amputated parts? Just throw an answer in there if you've treated them, if you've examined these people before. All right, interestingly, it seems to be coming out much more, well, it's a bit of a neck and neck between nail bed and soft tissue recon. With nail bed injuries taking 57% of the votes there. And yeah, that would be pretty much what I had expected. I mean, the nail bed injuries are quite difficult, and thankfully I've devoted a small section to nail beds and perhaps explaining why they're difficult. Fractures didn't get a mention there, so that's quite interesting. So nail bed injuries bother people quite a bit, and yeah, they bother me as well. Fingertips are absolutely immersed and steeped in controversy, and one of the reasons is that they seem simple. There's always a tendency to say, oh, it's just a fingertip, and there's this perception of being minor and simple to fix up. They're also quite complex. No two fingertip injury is the same, which is why they're always interesting to me, because no matter how long you do it for, everyone is different. There's different components injured and different considerations. There's also lots of options for repair and reconstruction and how you go about it. Patient expectations can be quite malleable, but any problems that happen are very difficult to ignore because they're forever in contact and the patients are forever reminded of it. So people are not indifferent to their fingertips. They're quite aware of them. And there's some fairly firm opinions out there about what should and should not be done. And I introduce things by saying we shouldn't be dogmatic, but there is a lot of dogma when it comes to fingertips. So we've got to tease that out. So there's lots of reasons why a simple, small area of anatomy can be controversial and difficult. The fingertip itself, and one of the reasons why it's difficult, is there's a lot of action in this one small place. And we talked recently at one of the registrar's tutorials about the anatomy here in the fingertip. We have the nail plate and germinal elements of the fingernail bed. We have the bone right underneath that, the joint's not far away. We have the sensory pulp here that's jam-packed full of nerve and sensory endings. The tendon insertions are nearby. So it doesn't take much in a fingertip to injure a lot of structures, and this is one of the reasons why everyone is different. It's different in terms of how much nail bed injury there is, what the bony injury looks like, is there a tendon avulsion, what's the soft tissue pulp like, and there will be different proportions of each. So the fingertip, is very complicated, and that contributes to this difficulty. And it's regardless of whether you're at a primary care level or all the way up to senior consultant reconstructive surgeon, these structures are important and difficult to put back together. And the more structures that are injured, the more difficult it becomes. Let's not forget fingertips are important. So one of the things I said at the start was that they can be written off as just a fingertip or just a small injury. But we use them constantly. We use them for data collection and sensing our environment. We use them for data entry when we're writing and using keyboards. They're our interface with the world around us. We grip and hold and pinch things regardless of our occupation. We use them for language, communication. They're cosmetically important, and they're more important than anyone ever imagines. Every patient I have will sit down and say, I never knew how much I needed my hand until this finger was out of action. So only when it happens to you and you've got a painful fingertip do you realize how important it is to have them functional. This is a quote a worker said to me some time ago, but it's always stuck with me in terms of unappreciated importance of fingertips. So this is just one element, but this worker felt that if he had an amputation, he wouldn't get a job. He'd go to a job interview. He said that at interviews for the companies that he would apply to, they would look at their hands in the interview, and if they'd lost fingers or they had finger injuries, they'd be considered careless and he wouldn't get the job. Not particularly fair, but it's one consideration. So as I said, fingertip injuries can be variable. You can just have skin loss, we can have skin and pulp, we can have amputations, nail bed injuries, fractures, and most importantly, as I said, combinations of all of these things. We'll talk about reasons for referral later, or reasons why a patient should receive formal surgery or review, but we'll cut to the chase and put it right up front. So some of the key things would be if they've lost a significant amount of the pulp, the volar pulp of the digit, a really significant nail bed injury or suspicion of it, compound fracture, which there often is, if the fracture pattern of the distal phalanx is unstable. If the patient is concerned and anxious is an important reason, because we do find in hands that patient anxiety escalates if some of those things aren't addressed. Pain out of proportion to the injury might be a reason for further investigation. If there's complex compensation or medico-legal concerns, that's another reason. And if there's multiple options and debate about the treatment, if there's multiple options available, maybe a referral's worthwhile for second opinion or to complete the picture and offer the whole spectrum of treatment. Even if it's fairly obvious, for example, that terminalization is the treatment, it might be worthwhile to complete the picture and at least offer or discuss a complex reconstruction so the patient has the right to refuse. The pitfalls. So although they're considered straightforward, easy and simple, there are considerable pitfalls. If a fracture pattern is unstable and displaces with malunion, it's quite difficult to fix secondarily. Same with nail bed deformity. Complex deformities of the nail bed are very difficult to fix in a secondary manner. If there's loss of hypernichial support, and we'll talk about the hypernichium in a moment, there's beaking of the nail, which can be painful. Poor soft tissue cover over the tip of the digit, again, causes pain. The bone's right under there. If there's not enough soft tissue, every time it's struck on a surface, it's painful. Global stiffness can occur even with a fingertip. Overt or overly excessive caution from the patient can cause the whole finger to get stiff and contracted. So we need to be addressing that. Hypersensitivity. Well, with pulp injuries, hypersensitivity is almost ubiquitous. It happens all the time. So, but counselling people about it and initiating treatment early is the key to undoing it. And then, as we said, there's return to work issues and other psychosocial matters that we need to deal with, even with fingertips. So we'll just start now listing off a few of these injury components. And I've taken more of an approach of having mostly slides and case examples, just to give an indication maybe of when a fracture is a problem or when a laceration is a problem, when it's not. In distal phalanx fractures, it's important to realise that they're often compound. So we saw the anatomical diagram earlier, there's nail plate, then nail bed, and directly under that is distal phalanx. So it doesn't take much of a crush injury to burst through the nail bed and fracture the distal phalanx, and there you have it. You've got a compound distal phalanx fracture. So we need to be wary of that. If the fractures are unstable, they need to be stabilised. The little tiny bones, they're very slow to heal. And as I said, hard to fix secondarily, but potentially quite simple early on. We have to also be aware that in the distal phalanx are the tendon insertions of the extensor and the flexor. So here's an example of a couple of fractures. A patient got both their middle fingers jammed, and they've got small little undisplaced fractures through the distal phalanx here. So this fracture pattern is quite stable. They had a nail bed injury, which is easily fixed, but that fracture there doesn't require any fixation. It requires monitoring and it requires some protection. So you might put a little finger cap splint on there and you might take an x-ray to make sure nothing's changed. But in general, the fracture pattern is quite stable. There's no displacement. This could be treated conservatively. This fracture pattern, however, is not stable. So we see the fracture here through the base of the distal phalanx. And hopefully people will clue on, particularly our registrars, why this is an unstable fracture pattern. But for everyone else, we mentioned the insertions of the tendons, and our extensor tendon inserts here on the base, but that's not our problem. Our problem in this fracture pattern is the flexor tendon, which inserts right across a much larger portion of the base of that distal phalanx. So this fracture pattern is prone to displacement. And initially it looks quite stable, well aligned, and it can be ignored or missed. And what can happen quite easily is that activity of the flexor tendon can pull that distal element anteriorly. And if that's not identified quickly, then there's a significant malunion. So this is an unstable fracture pattern despite being undisplaced. And as we said, difficult to fix if it's later on, but fairly easy to fix. Poor intraoperative imaging x-ray here, but with a simple K-wire across that fracture that's well stabilised and easy to remove later. Here's an interesting one, a longitudinal split. So in this circumstance, it's actually probably quite a stable fracture pattern, and there could be an argument for leaving that alone. The option for the patient, as I said, to complete the picture is that you could put a screw or a wire across that and bring those fragments back together. And this sort of fracture, it would be important to discuss that. So this would be something where, although it may be treated conservatively, a surgical opinion would probably be worthwhile just to give the patient the option. I would find that with patients in this type of situation, half of them would say, no way, if I can get away with a splint, I'm out. And half of them will say, look, I'd rather you went in and fixed it. That would make me feel better. And we're there for the patient, so we operate under their instructions. So this is the one where, although it looks reasonably good and it probably will heal, there are surgical options which are not too terribly invasive. This one's very similar to the last that we saw. So it's an unstable fracture pattern. Our flexor tendon insertion is here. There's going to be a likelihood of that falling off. So that needs some stabilisation. This, however, does not. So little tuft fractures, you often get those little comminuted tuft fractures where you have most of the structural element of the bone all intact here, and then dust up here of distal phalanx, that can be left alone. A lot of it will heal back together, but even if there's a small loose fragment, if it's not symptomatic, it doesn't matter. So we leave that alone. So this type of thing, if the patient's not experiencing any symptoms, I would leave that alone. This is our bony mallet injury. So avulsion of the extensor tendon insertion. And I've at least done a small previous session on that before. But our extensor tendon comes in and inserts on this fragment. The insertion is firm enough that it avulses this dorsal element of the distal phalanx. This is one that contains some controversy. So without that extensor, the finger will fall into a mallet deformity due to the action of the unopposed powerful flexor. But treatment options are multiple and there is a bit of controversy. So I'll ask this second poll to see what people find is the most common where they're working. So in terms of your experience and where you're working, what's the most common treatment for a bony mallet injury? Admitting that some of them are more severe than others, but there's a point I'm getting at here. So we're looking at a lot of splinting, getting up there at 67%, and that's going to come out as the winner as mallet splint only. So 67% said mallet splint only, and the rest went for closed reduction and K-wire. That's probably it is a bit of a geographical thing. Even in Sydney, north and south of the harbour, the philosophy is different between fixation and splinting. So there is a group where the philosophy is very much operate on everything, and there's a group where mallet splinting is the key. So you can have hours and hours of debate about that, and there's going to be those very firm positions. Nonetheless, bony mallet injuries are one that should have referral because of the option. The patient should be given the option of fixation. It's one of the situations where there's a large group that would do one thing, there's a large group that would do the other. If there is a suboptimal outcome, the question will always be, why was I not offered that? So bony mallet injuries particularly, if they're displaced, they should be discussed and they should be given the surgical option if they so desire. Now, having said that, personally, I put them in a mallet splint most of the time and the results are good. Why do I put them in a mallet splint? Well, it works, and that's what I would do to myself. There's no way I'd let anyone operate on my mallet finger. I would have a splint. So, but as I said, patients will go one way or another. So I will offer them an operation and I will tell them that it's completely fine to have an operation. There's nothing wrong with that, but they do have the option of splinting. So it's just part of completing that picture. But it is a controversial one. Not like this next one, which is the Jersey finger. So this is the opposite injury, essentially, where our flexor tendon insertion, as I said, it inserts over a much larger area, has been pulled off. So no controversy about this. This is a surgical injury. This needs a complex reconstruction and even more complex rehabilitation if we're ever going to move that distal phalanx or that DIP joint again. So this is the Jersey finger or flexor tendon avulsion fracture of the distal phalanx. Thankfully, a lot less common than the mallet injury. So nailbed injuries is the next one, and we have had a little Q&A come through about the best way of draining subungual hematoma, and this is what we're talking about. So if you see this present, these are subungual hematomas. Now, firstly, why is subungual hematoma a problem? Well, for one, they're quite painful when they're tense, especially, this sort of tension in a hematoma here is quite uncomfortable. But secondly, they can cause pressure ischemia and necrosis of the nail bed if they're under enough pressure. The next thing is that why is there a subungual hematoma? Well, there is a subungual hematoma because there's a nail bed laceration. So the subungual hematoma is a symptom of the actual problem. So that's why they're of interest to us. We need to consider them because they're painful. You can get ischemic necrosis. We have complex nail bed lacerations underneath, which can cause significant nail bed scarring. Now, that scarring is a problem if it causes deformity of the nail. That can cause ridging, lifting, avulsion, paronychias, impaction. And most importantly, our secondary reconstruction options are very limited. Once you have a deformed nail or nail bed and it's heavily scarred, there's not a lot we can do to fix it. So it's a relatively simple primary problem with extremely complicated secondary issues. So that's why we have to consider them very carefully. How do we drain these? Well, there's two ways to drain it. One is the trephination that you talk about. But trephination is really for symptom control. If they're really, in a lot of discomfort, you might trephine this just to let out. What I mean is you get a needle and you actually put a hole in the nail plate and allow some of that pressure out. However, in all of these circumstances, I would recommend removing the nail plate. That is the definitive way of draining the hematoma. And it also gives you an opportunity to inspect the nail bed. And why? You want to see where that laceration is, how severe the laceration is it communicating with a fracture underneath? And that will dictate the treatment from there. This one here is interesting, although it looks like the less sinister. The laceration and hematoma is more proximal, which is important because this is the germinal area of the nail from the lunula more distal beneath the eponychial fold here. So this is more likely to involve our germinal matrix, and germinal matrix injury is much more significant than sterile matrix injury. So there could be an argument made that more distal, if you have a hematoma distally on the nail, say beyond half the nail, or certainly beyond the lunula up here, maybe that's not as significant as anything more proximal. But in any case, I would recommend removal of the nail to definitively drain out all of that infection, giving it a wash and being able to inspect the underlying injury. So we mentioned that. So we're mentioning a couple of those little terms I just used there. So the lunula is that curved white opacity. It's white because of the nuclei still present in the cells. And it is the junction of the germinal and the sterile matrix. The hypernychium I mentioned earlier on, and it is the massive tissue just distal to the nail before we extend onto the pulp. So it's sort of the support area at the distal nail. Nail growth is extremely slow. The nail germinates back here beneath the eponychial fold, as we said, and then we have the germinal matrix, and beyond that, the sterile matrix distally. And as you said, directly underneath is the bone. Just a couple of stats here, and it is widely published, this sort of thing. If there is nail bed injury, the deformity rates are very high without repair. So, in one study here, approaching 50% with children, and the adults approaching 20, just over a quarter will have nail bed deformities if not repaired. And what do we mean by deformity? So this is the sort of one we're talking about where you have significant germinal matrix and nail bed scarring, and you have this bifid nail with nail horn growth, instability, and sort of loose keratinization. And that's a real problem for anybody to have, particularly our workers who are putting on gloves every day and they're jamming into this. It's very painful, and it can lift this nail off and they can have recurrent infections. It's not a situation where you want to get in. And the treatment for this, all we've got is complete nail ablation. We just would remove the germinal matrix and ablate the nail completely. So there's no other good reconstructive options for that. This is the beak nail I was talking about, where there's some loss of bone, there's loss of hyponychial support, and the nail bed falls into this beaked appearance. So complex secondary issues, and there's no good solution. So to repair the nail bed, we need to have adequate support from the hyponychium and the bone. We need to just debride as little as we can, because we won't get any advancement from the nail bed. So if you debride too much, you've left yourself whole, and then put it back together as carefully as possible. In general, when we're doing it, we do it under magnification with fine sutures to just get the best repair possible. Fix any underlying fracture to make it stable. Now, the big one here is if there's significant defect. So if we have a large defect, grafting might be useful. I'll mention that again in a moment because it's not as simple as it sounds. the other thing we consider is primary ablation. So I mentioned ablation before with that bad case, but we might just ablate the nail. If there's too much loss and we've lost all the way back to germinal matrix and there's no sterile matrix available to support a nail, well, there's no point in growing one. And so we will just ablate the nail completely. If the nail bed is lost, but there's distal phalanx, then we might consider putting a flap over the top to maintain the length of the digit, but the person would never have a nail. They would just have skin graft or a flap over the distal digit. So in that sense, we're going for function over form. And if there is an amputation and there's a nail bed in it, we might consider putting that back on, but that's better in kids. The graft reconstruction I mentioned. So if we do a nail bed graft, we would generally use another digit or mostly the great toe to take some nail bed. And, you know, remember we talked in our previous tutorials about replacing like with like and respecting the anatomy. So if we want to replace like with like, we need to replace nail bed with nail bed. We have to get that from somewhere. And we would take it from the great toe. But I'm telling you, that is a really unpleasant operation and very unhappy patients. You've got to take their great toenail off and shave a bit of nail, germinal matrix, and then plant it on their thumb. Not happy people, not a great operation. It might work, it works okay, but I've never had anyone that said, that was fantastic, I would do that again. They mostly would say, had I known that, I would just not have done it. And that's an important bit of feedback. Reverse dermis graft is the other one. So actually taking a bit of full thickness graft and taking off and de-epithelializing it, taking epithelium off, turning it over and putting the dermis back in reverse. Now, that's perhaps useful. I use it every now and then. You can't use it for germinal matrix. It's just for sterile matrix. Now, it seems to work okay, but I'm not really sure whether the graft is doing a job as a biological dressing and the germinal matrix is just growing underneath it, or whether it is actually this reverse dermis that's creating the structural support for the nail plate. In any case, it is a biological dressing, and I use it every now and then if I've got a loss of sterile matrix substance. So it's something to keep in the armamentarium if we're needing to graft. I mean, it's also just important from a primary care point of view to know that if there's a chunk out of the nail sterile matrix, that it's not a lost cause. There are some things we can do primarily to try and salvage the sterile matrix and provide for nail growth later. Now, if it doesn't work, maybe, you know, we have to revise. But again, it's something that we can offer the patient as a trial of salvage. So amputations. So this, is the classic type of amputation. And this is the one I just mentioned before, where we have an amputation that involves most of the nail or the nail matrix, but it's basically from the level of the lunula distally. So we will germinate a nail, remembering the nail germinates from back here, but there's nothing to support the nail distally. However, actually looking at this is probably lunula here. This is our sterile matrix out here. So we've lost about 50% of our sterile matrix, I guess, and we've got a nice transverse amputation. So options here abound, but this is a neat transverse sort of mid-distal phalanx amputation. I think that's the same person cleaned up and in the operating theatre. So as you look at it from the different angle, we've got slightly more nail matrix there. In any case, very similar. Now, it doesn't look like the same one. That's similar, but not the same. In this case, we've got a lot less skin on one side, and we've got a lot more of this sterile matrix. And this is the same case, definitely. So we see we've lost the distal part of the distal phalanx. But the important thing here, joint looks good. We know that our tendon insertions will be intact, and the remainder of the bony structural integrity is intact. So there is a bone there that will move and function and provide digital length. So we've got some germinal elements, we've got some stable sterile elements, and we've got a bone underneath with tendons attached that will function. If you're going to terminalize this digit, you have to come all the way back here, and they lose quite a lot of finger and quite a bit of function. So it's one where we'd consider reconstruction. Here we would definitely consider reconstruction because it's the thumb. And as opposed to the digits, our thumb is unique. There's only one of them, and we need it to have the maximum length to be able to perform its tasks in opposition to the digits. So here, where we've lost mostly or all pulp and hyponychium, but we've got most or if not all of the bone and most, if not all, of the nail matrix, this is a prime candidate for reconstruction. But are we going to reconstruct it by putting this back on? So this is another consideration, is distal replantation, and I'll talk about that in a second. Oblique fingertip injuries can be confusing, mostly because of description. How do we describe these injuries? But also because of the soft tissue availability. The more volar oblique they are like this, the less chance there is of any type of local reconstruction. But in any situation, you can see the problem here is this is exposed bone, and we've lost all of that hyponychial support for the nail. So any reconstruction, even in this situation, that does not provide hyponychial support is going to result in a big nail appearance. In this one, it's even more tantalizing because we've got most quite healthy, intact and normal. We have our germinal nail elements. We have a lot of sterile nail. We've got most of our bone, but this significant radial oblique injury. So this would be radial oblique. Here's the other side of it. So lots and lots of good finger left behind, but exposed bone and loss of pulp. Just looking at that terminology, so transverse, dorsal oblique, and volar oblique, and then we had radial and ulnar oblique. So just referencing with respect to the angle. And that's important when describing if there's a referral going on, and say there's an amputation and it's volar oblique through the level of, or dorsal oblique through the level of the lunula. That's very useful. So this is that fellow again with that amputation but a good bone, and we'll talk about him in a moment when we discuss some reconstructive options. So when we're reconstructing, we've got some principles. We obviously want to get it healed, number one. We want to preserve as much length of the digit as is possible and reasonable. And as I said, with the thumb, that standard goes up a lot higher. So thumb preservation of length is paramount. We want to maintain joint function if possible, and we want it to be stable. We want to maximise sensation if we can. We want to maximise the cosmetic appearance of the digit, admitting that people are not indifferent to the appearance of their fingers. And we want to avoid any secondary injury, and that's either through commission or omission. So we don't want to do a whole lot of crazy surgical dissection and do more damage through our surgery. And equally, we don't want to splint someone for an excessively long period of time and create contractures. So we talked about some reconstructive principles, and we remember we spoke last week in our lacerations session about our reconstructive wagon wheel, and nowhere does this apply more than a fingertip. So we've got all of these options available to us, but we don't have to select one. And that's why we have the wagon wheel. We might choose to let an area heal by secondary intention, put a full thickness graft on another area, and then do a local flap to a third area. So we have all of these things available to us, and we should think about using whatever we need. Just allowing it to heal. So this type of injury where we've just lost a little bit of pulp and maybe a tiny bit of that that sterile matrix, this is suitable for dressings. This type of injury doesn't need any surgery. It's okay to dress it, and they actually heal quite quickly, and some of that blunting effect fills out and the shape of the digit returns. There are numbers thrown around like a centimetre squared. If it's less than a centimetre squared on the pulp of a digit, you can dress it and allow it to heal. Providing it's pulp only and there's no bone exposed, that's probably a reasonable guide. So just dressing that would be okay. Here's one that might be, I've switched over again, but hopefully everyone can still hear me. This one, again, this is pulp, but might just be on that borderline of something we might want to put a graft on. It's maybe at a centimetre or a bit more, but it's also right on the pulp where we want some very stable skin. So this type of situation, you could dress it, it will probably heal okay. But equally, it's something where, again, the patient may want to have the discussion about options. Again, this is a burst laceration at the fingertip. The patient also has a nail bed laceration and a small distal phalanx fracture. For this burst laceration here, you may consider just dressing it and it will probably heal okay. However, again, it's on the pulp of the digit. A thick ball of scar tissue from healing by secondary intention in this location may not be optimal. If you're looking at this patient and you're equipped to be able to debride this and suture it, then that's what I would recommend. Which brings me to a little point. If you're looking at a fingertip laceration or loss of tissue or an injury, and it's in your capability to improve the situation or fix it, then I would advise fixing it. If you have this type of injury where there's a burst and an open wound and it's in your capability to put in a digital block, clean that up and put some sutures in, then I think you're going to make, or I don't think, I know you're going to make the patient's situation better. You'll decrease their healing time. You'll decrease the amount of granulation and scar tissue in that fingertip, and they'll have a good outcome. It will heal by itself, but if you can improve it, then do it. Why do we need to consider soft tissue? Well, this is just what I mentioned with that primary suturing. We want to decrease healing by secondary intention. Granulation tissue and secondary intention in the hand is bad, universally not good. So we want to try and avoid it. It reduces hypersensitivity if we do a primary repair and we clean everything up neatly and surgically. We want to maintain length, as we said. We limit scar and we limit stiffness. We want to cover up important things and maybe even speed healing. We might say we're going to dress it, but it's going to take 4 weeks to heal, whereas a primary closure or a graft might take 2 weeks to heal. And we've saved a person 2 weeks of their life. When to reconstruct, we want to preserve length, to provide nail support, to cover vital structures, provide padding for the finger over the bone, prevent contractures, provide sensation. Sometimes we can use neurotized flaps and improve the appearance if need be. So what flaps can be used? Now this is not a flap tutorial, so we're just going to mention them so we know what's available. And there's these homodigital type advancement flaps where the vascular pedicle on one side is used as the base of the flap and they're advanced up to the tip. As I mentioned in another tutorial, I'm not a huge fan of them. They create a lot of tension on the hyponychium. They almost universally result in beaking and distal wound breakdown. They're uncomfortable. I'm not a fan of them, but many are, and so that's why I mention it. Heterodigital flaps, so when we're using tissue on a vascular pedicle from another digit and transferring it. Now, these are better because they're often not under tension, but they do create a lot of dissection. As I said, we're trying to avoid secondary injury, so we don't want to go digging around in the volar digit if we don't have to. Occasionally you'll have to, but if you can avoid violating the natural part of the finger, then do so. Heterodigital flaps can also be the two-stage flaps, like a cross finger, and a bit more information on here on this one, because I will express my personal bias for this, and this is my reconstruction of choice. And you're going to have to put up with me explaining why and showing you some examples. Now, it does have disadvantages. It is a two-stage procedure. There is a donor site on another digit, and if they don't do their therapy, it can result in significant stiffness. So there are problems with it, but we just have to be aware of those. Also, we don't want to do it in people that are otherwise compromised in their hands, and the older the fingers and more arthritic, the less likely they're going to move. But the cross finger is based on this theory of unfolding the dorsal skin of the digit and transplanting it in to the defect, then allowing it sufficient time to take there, 2 weeks is enough, and then dividing this pedicle through here. And that way we get this nice flap of tissue. So back to this case here, and that's what a cross finger flap would look like from the neighbouring digit. So it allows us to place this nice piece of tissue here, not under any tension, on the tip of the finger to provide padding over the bone and maintain all of this length of the finger. When they're divided, this is what they look like. We've got good padding. We haven't violated this part of the finger. The neighbouring donor digit is moving well, all the way into flexion, and our graft on the donor side is healing. So this is a nice reconstruction, in my opinion. And you can end up with these tips to the digit that look almost native. That looks like it should be there, but it's actually, you can see down here, that is actually a cross finger flap. For this case we saw before, here's a double cross finger flap. So we had all that nice finger, so I couldn't resist trying to put them both together. So double cross finger flap fills up that defect nicely, and when divided creates this really nice plump reconstruction of the pulp. You can't get that from many other techniques, and it hasn't violated this part of the finger, and it provides good hypernucleal support. Getting even more complicated, so here we have a avulsion of most of the volar thumb, as well as the index and little finger pulp. And so this is where our wagon wheel's coming in. This is what I mentioned before, where we've got bone and we've got all our sterile matrix, but just missing the pulp. And so from our wagon wheel, we take a few things here. This is a Fouché, or first dorsal metacarpal artery flap, to reconstruct the entire volar thumb with some sensate skin, and then a double cross finger flap with our donor sites on the central digits. So providing, again, this nice pulp skin and quite a lot of it, bulky, soft tissue to cover those digits. So here's another example. This was a laceration, which was sutured primarily, and this was a cross finger flap reconstruction. You can see one of the downsides here of the cross finger is they're just growing a bit of hair there, but I just tell them to shave their face and their finger a couple of times a week. If we don't have any other options locally or regionally, we can do something like this. Now this thumb is buried in the abdomen, so we raise a flap of tissue off the belly and we insert the thumb into there and inset it in exactly the same way as we do the cross finger flap, and we allow it sufficient time to take and then divide the pedicle. Disadvantage, of course, is that defect and the positioning for that period of time can be quite uncomfortable and create stiffness. There's a donor site scar, and it can be bulky if the abdominal skin's thick. So there's sort of some of the reconstructive options. Now, I mentioned before with that thumb case, the distal replantation. Quick question then, do you consider distal digital replantation to be useful? From anything that you've seen, is it something worthwhile? This might be controversial. It probably is against, this is probably controversial amongst hand surgeons. If you sit a group of hand surgeons down and ask them about this, there's probably going to be a debate. And we're coming out to almost 50-50. We're 60-40 at the moment. Or maybe we've got in favour of a yes. So 67% yes, 33% are a no. So 2/3, 1/3 there, with most people favouring doing a distal replantation. There's a little classification of distal replantations here depending on the position to the nail bed and matrix, and some of that also relates to the vascular supply and the arborization of the vascular supply. For the registrars, that would mean Then the more proximal ones, we may have the opportunity to anastomose a vein as well. But the more distal it is, to anastomose a vein as well, the more distal they are, you're not going to get a vein. You might get an artery, and you have to consider other outflow techniques. So it is possible. We just have to preserve the part and transfer them as soon as possible. It does require a complex discussion with the patient, but it is really good when it works. In terms of preserving the part, remember we got the amputated part washed into moist gauze into a plastic bag and then into an ice slurry. So the things we don't want is the amputated part directly in contact with water, and we don't want it to be frozen. So the ice slurry keeps it at a cool temperature but not freezing. So if you freeze the part, you'll get cellular lysis, which is going to mean you're going to have a reperfusion injury or cellular death. And if it gets wet, it's going to macerate and be hopeless. So washed, moist gauze into a plastic bag so it's dry-ish, it's moist but dry, and then into your ice slurry, and you can preserve it like that for quite some time. Now, the metabolic demand on a distal bit of pulp is extremely low. So you can get away with this for, at least a day, and I've seen them put on longer than that. So for the regional and remote people, you do have some time to get the person packaged up and transferred as long as the part is preserved. And for our registrars and everybody, you do have time to get the people and equipment that you need to attempt this if you're going to. So there is time. You can put it in the fridge. You can preserve it in your ice slurry and get them where they need to go. And if it takes 24 hours, you're probably still going to be fine. So our amputated Parkinson's thumb is a classic example. We discussed with the patient, they wanted to have a crack at it, and we put it back on. We discussed this one last week. As I mentioned, we could only do an artery. You can't do a vein at this level. And so we have to keep pricking it and bleeding it out, or we recruit our helpers to bleed it out for us. So bleaching is good in this circumstance. And in this case, we won, and it's a beautiful thumb reconstruction. So nothing reconstructs a fingertip like a fingertip, and when they work, they're beautiful. When they don't work, they're horrible. So in this situation, there's been a complete failure and necrosis of the attempted distal replantation. So it's something to have in mind. They don't always work, and it's what we need to discuss with the patient. This is what it involves. If we get it to survive, you're going to be here. We're going to be bleeding out of your tip of your finger for 10 days or more. We're going to have potentially leeches attached to it. You're stuck in bed, you're anticoagulated, and it might not work at the end of all of that. And so it's a complex discussion to decide whether you're going to do it. And then once you're committed, you're not guaranteed to win. But distal replantation is something always to be considered, again, especially in the thumb. So we'll go back to this reasons for referral. So significant loss of the pulp. We saw some options. We had to put them back together, so it's not a lost cause. If there's suspicion of, or if there is significant nailbed injury, if there's a compound fracture that we're worried about and contaminated, it's unstable, those unstable fracture patterns, patients worried, pain out of proportion, complex medico-legal, or if there's that need to complete the picture for the patient. To prepare them for transfer, same as last week. It's exactly the same slide. You want to have an anatomical description, make them stable, no tourniquets on the digit, all of their covers, and a nice, comfortable resting bowl or slab. We showed this last week. This, even for a fingertip injury, it's a nice, comfortable position to put the hand so they can keep it elevated, rest, and not contributing to any further trauma. So this posi splint is the winner for any hand injury. And if we see people coming in like this, we know that the primary care has been all over it. So that sort of comes to the end of our brief overview of fingertip injuries and some of the complexities of it, some case examples there. And hopefully that's useful. But as I said, they're all interesting. They're all complicated in their own way. And I still don't find them easy. I do find them very interesting though, and every time I sit down to operate on one, I'm amazed at how many elements of that wagon wheel we have to employ to adequately reconstruct a fingertip. But people aren't indifferent to it. So put the maximum amount of effort that you can into fingertip injuries. Again, for our registrars, really take fingertips seriously because they're just so important for people and their daily function. And some of my happiest patients are the ones where we've created a good fingertip out of a bad situation. So if there's any questions, please pop them in the Q&A now. We did have another question about how much pulp loss is too much. Hopefully I answered that through that section where we talked about, you know, small areas, maybe a centimetre squared or less, not exposing the bone, that's fine to dress. And if there's much larger areas or there's exposed bone underneath, we might be looking at considering referral. Now that's a ballpark. If it's 1.5 centimetres and it's, you know, in a non-contact area, it might be something just worth a photo and a phone call. That might, you know, rather than sending the patient on, just some photos and a phone call might give us an opportunity to give some advice and options. So we do have another question come through here, and that is, can you please outline when do you use a skin graft in a fingertip injury? So, I mean, the basics of skin grafting is that you need to have a bed that's going to allow the graft to take. So, you know, remembering for everybody else, the difference between graft and flap is that the flap comes with its own blood supply and the graft needs to take up a blood supply in its new location. So I would use a graft on a fingertip when there is a significant pulp loss, but there is a reasonable amount of pulp remaining on which to graft and which has enough padding. So remembering we need the graft to take and we need the fingertip to have sufficient padding to be functional and pain-free. So you might have a shaved loss of the volar pulp that's 2 centimetres squared, it doesn't expose the bone, you know, and it's nice and plump and a beautiful grafting bed. I'd use a graft there. You might have a radial oblique loss of pulp down one side, which might be 1.5 centimetres long and 0.5 centimetre wide, but takes up a whole sort of hemi-digit, but the pulp fat underneath is stable and plump. I'd probably use a graft there. And the other time I might use a graft is if a patient, I talk to them about cross fingers and they say, you know, doc, I really just don't want my fingers sewn together, but I don't want you to chop it off. And in that case, I would say, okay, well, look, I can put a graft on there and we can see how it goes. So that doesn't require 2 stages. The problem is that it might be a bit thin. You might have a bit of discomfort, but it will get you healed and we'll see how it is. And there's a few people that will opt for that. So that's, again, it's a complicated answer, but use a graft firstly when you can, when the vascular supply and underlying tissue will allow it. And secondly, if you're in a situation where there's no other option or the patient doesn't want to do anything complicated. Hopefully that answers the question. If it doesn't, put a sub-question in. So I've got another question. Does the PIP joint tend to get stiff in cross finger flaps? Yes. So, yeah, obviously you've got the finger in an abnormal position. Now the key to that, as I said, so a problem's only a real problem if you don't recognise it and don't deal with it. So my patients with cross finger flaps at the stage 2, I keep them in hospital overnight at the division and they're off to hand therapy in the morning. So at 2 weeks, they have a division. At 2 weeks and 1 day, they are moving into a full fist and straightening out to full extension. And if we get that happening there, we're okay, and we just maintain it. The difficulties arise if you don't divide them for too long, so you leave them 3 weeks, or if you do the division and see them a week after that and they become stiff, and then that's the problem. Part of that, though, is a little bit of preoperative discussion and assessment and gauging the patient beforehand. So you do have to tailor the operation to the patient a little, make sure they're capable and willing to participate in the rehab as much as you can, and then get onto it. So day one, full range of motion with that finger flap. So yes, that's absolutely a serious consideration. Another question, what is the sensation in the digit usually like following the reimplantation versus the skin graft? Well, fairly similar. The replant, you might be tacking a small nerve together, but your sensory recovery is relatively poor. They will get some proprioceptive recovery, but it's going to be fairly poor from a two-point discrimination point of view. And the same with a full thickness graft. Their sensation is not going to be great. Now, that's one of the arguments for the homodigital flap, is taking some of the tissue and advancing it and hoping that you've got nerve endings in it. But the damage that you do to the volar digit in order to potentially achieve that, I've not ever seen it to be particularly worthwhile, and the incidence of hypersensitivity over the donor area of the volar digit is too high for me. So sensory recovery is not great, but that's got to be traded off with the length of the digit, mobility of the digit, and adequacy of the pulp and bone coverage and nail plate stability and things like that. So, of course, as another caveat, that's much less important in the central digits to the border digits. So our border digits, our sensation is more important. And there's a bit more of an argument that you sacrifice a digital nerve from a non-border and put it into a border digit in order that people have protective sensation for pinch or resting their hand on the barbecue, etc. So overall fingertip reconstruction and sensory recovery is not great if we're using graft or flaps, but the location might sometimes influence us to do a different operation. And another question, how long can you wait to treat the subungual hematoma, and when is it too late, considering late presentation? So one of our features that we mentioned before of subungual hematomas is they're painful. So if they have a really significant subungual hematoma, they're unlikely to wait very long unless they're super tough bushies, which is possible. But when they're really tense, they're going to be painful. So firstly, they're unlikely to delay too long. If they do come in and they're 2 weeks down the track with a subungual hematoma, there's probably not a lot of point then. The nail's just going to eventually fall off, and at that stage, it's probably too late to repair much of the scarring. So that leaves a big window, doesn't it, of 2 weeks. Well, if you think about the healing of the nail bed, it's probably mostly going to be healed and adherent within the first 7 days. So I would say if you're inside 7 days, you're probably in a good time frame to be able to take the nail off and assess the nail bed. If you're outside 7 or 10 days, it's probably getting a bit old. And you'll see that by then the clot's starting to organise and it's just not as pretty. So inside a week, you're probably on a winner. Outside a week or 10 days, it's not going to be as useful. But anyone with a really bad laceration and tense subungual hematoma, they're going to be seeking your attention pretty quickly. All right, any other questions at all? We've come to the end of the list. That was a good round of questions tonight and all good stuff. Hopefully that was useful. They are complex. An interesting thing about this topic, as I've said, is it's difficult for everybody. It's difficult for me, and it's difficult for our junior registrars, and it's difficult for primary care, and they just are hard because of the number of anatomical structures and how important they are. So, in signing off, I'll just remind everyone again of that fingertips are so important, and if you're worried about people, or if they're worried, then get some more advice and see if there's any other options to make them better. So that would be it if there's no other questions for tonight. And please leave us some feedback again and other topics you'd like to hear, or different ways you'd like this information presented. Hopefully that's been useful, and we'll see you again very soon. So thanks very much, everyone, and see you next time. Bye.